Hello, everybody. Welcome to this YouTube channel. I am Dr. Andrea Furlan, and today is my great pleasure to have a guest on my channel. This is Dr. Diana Guernita. She's a rheumatologist in the United States. She also has a YouTube channel, and she does provide consults, telemedicine for people in the United States and internationally. Her program is called Rheumatologist on Call. I'm going to put all the links where you can find Dr. Diana Guernita on YouTube, Instagram, her website, her courses that she has, a course for patients, and also how you can find Rheumatologists on Call. All of this you can find on the description of this video below. I would like to thank everybody who sent questions, because I put a call on my social media post saying, I'm going to interview a rheumatologist, please send your questions. And 52 people sent questions to us. We selected 20 that we think are most appropriate for this session today. But thank you for everyone who submitted your questions. So let's start, Dr. Diana.
Thank you so much, Dr. Furlan, for inviting me. It's a pleasure to be here to help your patients and help your audience to understand more about arthritis and autoimmune diseases.
Okay, so Dr. Diana Guernita, here is our first question. And I'd like to ask you, is there a cure for arthritis?
This is a wonderful question because a lot of people will ask me this question in particular. Arthritis is a general term that defines more than 100 types of arthritis. And because there are different types of arthritis, from wear and tear to inflammatory arthritis like gout and pseudogout, or autoimmune types of arthritis like rheumatoid arthritis or psoriatic arthritis, we cannot talk about a cure of arthritis. But all of these diseases, they have treatments, and with the appropriate treatment, those diseases can be very well managed.
Oh, that's so good. Yeah, give hope to people. That's so good. Okay, another question. Have you ever witnessed any remission with your patients? And if so, what would be a way to achieve this?
So it depends on the type of arthritis. If we talk about rheumatoid arthritis or psoriatic arthritis or even lupus, yes, I have seen many people getting into remission. But what remission means is it means that with the right treatment, with the right monitoring, and with direct communication with the doctor, people are are transitioning to no disease activity. I mean, no symptoms. Their markers of inflammation can be normal. So that's what we call remission. Remission is not cure. Remission, it doesn't mean that your disease will disappear completely. You can also lower the dose of medications and you can still stay in remission, but all depends on the type of patient and whatever other unique approach you have for your patient. So yes, remission can be achieved.
Yeah, and the next question is very similar to this one. I grouped them together. Can autoimmune diseases go into permanent remission?
So if people are referring to permanent remission, meaning that it's a cure for autoimmune diseases, permanent remission is not possible. Remission can be achieved, as I said previously, when you have no symptoms, when your markers of inflammation are normal, many other organs are not affected, and when you are on treatment, even minimal doses. But if you are on some treatment and you have no disease activity, that's what we call remission.
Yeah, but I think they were thinking then, have you seen people who had never had a relapse, a flare up again? So they were in permanent remission because they needed minimal medications and you never saw the disease coming back again.
I have seen many people, and those are the people that they do incorporate a lot of lifestyle changes. They address their sleep, they address their stress level, they address their nutrition, but they also follow up very constantly with a physician, and they stop smoking. Okay, that's also something that I have seen, especially in people with rheumatoid arthritis. It appears that smoking is the bad habit
Wow.
or the bad habit that will increase the risk to develop the disease, the disease will be more active, the lung disease will be more active, and then the response to treatment is decreased
Wow.
because of smoking.
That also includes secondhand smoking?
Correct.
Okay. And before we continue, let me remind you that this video is not medical advice. This video is for educational purposes only. If you have a condition that seems like arthritis, please talk to your doctor. And if there is an emergency, please call an ambulance or go to the nearest emergency department. Another question. What is the most difficult part about managing rheumatoid arthritis for patients and for you, for the treating physician?
I will tell you from my experience what is my most difficult part. So to make them understand, to make them understand that, yes, they do have an autoimmune disease, but that autoimmune disease is not the end of the world. Sometimes when they hear about the diagnosis, it's very, very stressful. But what I tell them is that look at rheumatoid arthritis, for example, as you would have diabetes or high blood pressure. With the right medication, with the proper treatment and the proper follow-up, you're going to be under control, you're going to be safe, and you're going to feel better. So understanding where you are in the disease process and the complications if you don't do anything, because there are patients that they don't want to do anything. And here there are multiple layers that you have to kind of peel out. First is where the fear comes from. And the fears most of the time comes from unknown. First, unknown. And second, from the bad experience that others have. And here, social media plays a huge role because there are all these, I would call them toxic support groups where people come in and they say everything that goes wrong with them. And then if you take that experience on yourself and you feel like, oh my God, if they had so much side effects, I'm going to have that. So that's another barrier that for me as the physician is very hard to overcome. And then Googling symptoms, Googling symptoms, it's horrible because you're going to feel like in 5 years you're going to die, or in 5 weeks where you're going to die. So that's not really good. And then this, I see a lot of people that are hating doctors, or they hate pharmaceutical companies, or where they think there is a connection, a dirty kind of connection between us as doctors and pharmaceutical companies. But the reality is that on one hand, we help you to diagnose and treat you. And on the other side of the spectrum, they also help you with all this research that was done by very intelligent people, many of them doctors or with doctorate degrees, that will help you get your disease better. And what had happened, especially in my world, in autoimmune diseases world, without that help, the research help, it was not possible to have the treatments that we have today. So I want people to understand that there is not a dirty shake hand between us, and we are there to help them.
Yeah, in my world, there are all the opioids and anti-inflammatories and medications for pain that some people think they're evil and they are killing people. They do, but there are people with chronic pain that they need, their quality of life is so much better when they take medications because they have some kinds of chronic pain that are impossible sometimes to treat or to relieve without medication. So we do need, I think we physicians are kind of in the middle. We're in the middle between, those who are making profits out of selling products, and also in the public view, because they're bombarded with so many interventions and things that promote like the cure for rheumatism, the cure for chronic pain, with very little research or poor research, or things that just people make up in their minds. So I'll stop here because I could be talking about this forever and ever, but thank you so much.
You are a researcher. You are a researcher, and I was a researcher myself. I did a PhD. You did a PhD.
Yeah.
We know how much effort is that comes with that kind of research to come up with an idea, that idea is translated into a medication and further on tested and further on applied to patients. So it's a long, many times painful process that you have to go to come up with a solution. And when that solution is there, it's very easy to criticize, but it's hard to come up with a solution. So for many of the autoimmune diseases, 20 years ago, there were no solutions on the market.
I remember that. I graduated 31 years ago. And I remember when I graduated from medical school, all we had for rheumatoid arthritis or autoimmune disease was cortisone, methotrexate, gold. That was it.
That's correct. That's correct. And what are we talking today? We talk about CAR T-cell therapy, okay? So much more advanced, where we influence our immune system or the immune system cells at the genetic level. And we talk about gene therapies. So all these things are there because even the pharmaceutical companies with all their researchers, they put the effort into this. Of course, there is profit. Of course, there is, but there are so many layers that you have to peel to understand where are you and what do you need and who are your true allies.
Yeah. And I think where we are today with pain, chronic pain and fibromyalgia is probably where you were with rheumatoid arthritis 30 years ago. I think in a couple of years, we're going to understand much better the pain system, and we're going to have molecules and substances that can regulate that pain system, especially to help people with fibromyalgia, which is a biological disease, but we know the problem is not in the muscles, although here is where they feel pain, but the problem is in the pain system. So we do need to regulate that. And it's promising that neuroinflammation seems to be coming as a promising target for fibromyalgia.
A lot of my patients will have fibromyalgia, so I will make an invitation to you to come to my channel and explain to people about that.
My pleasure. If you are a healthcare professional, I'd like to offer you a free handout that I prepared. It is a handout that I use to explain the differential diagnosis of the various types of arthritis to my medical students and residents. Go to the link provided in the description of this video below and download this handout today. So now back to the interview with Dr. Girnita. Dr. Girnita, can you please explain the differences between osteoarthritis and rheumatoid arthritis?
Sure. First of all, there are many types of arthritis, and rheumatoid arthritis and osteoarthritis are just a few of the 100 types of arthritis. The difference is big. Osteoarthritis is a wear and tear arthritis in most cases, and it's usually an arthritis that comes with age, with overuse, and in people that had multiple episodes of trauma, that they were professional athletes. And on the other hand, on the other spectrum, we have rheumatoid arthritis that usually starts at a young age. It can happen to start around menopause for many females, but usually is someone at a younger age, between the age of 20 and 30. The difference is also in what kind of joints are affected, because osteoarthritis will affect joints that will be under a lot of stress, like the thumb for females, or the knees, or the hips, while rheumatoid arthritis affects multiple other joints that otherwise they are not affected by arthritis. So will be the small joints of your hands, and it's both sides at the same time, both hands, both knees, both ankles, or both feet at the same time. And what is also very specific is that rheumatoid arthritis starts with a lot of stiffness that happens in the morning. And as the day goes by, that stiffness goes away and you feel better. While osteoarthritis, you feel a little bit of stiffness in the morning, but then as the day goes by, if you overuse your joints, you're going to feel much worse.
Thank you so much. Yeah, that's very interesting. I mean, some people may have both.
Correct. Very true.
Thank you. And the next question is similar to this one, which is what is the difference between osteoarthritis and psoriatic arthropathy in terms of symptoms and diagnosis?
Because we just explained the osteoarthritis, now we're going to concentrate on psoriatic arthritis. So in many people that have psoriasis for many years, usually after 10, 15 years of dealing with the skin disease, about 25% of patients will develop what we call psoriatic arthritis. And this is, again, an inflammatory type of arthritis, an autoimmune type of arthritis that affects the joints. If we have to compare it with rheumatoid arthritis, it can affect joints in multiple areas, but it's not symmetric, it's not bilateral. You can have one finger here, one finger on the other hand, you can have a toe that is affected, or you can have the knees, but you can also have the spine, which is very rarely affected in rheumatoid arthritis. Again, I'm going to talk about the morning stiffness, which is specific for all the inflammatory arthritis. Morning stiffness lasts more than 1 hour. And what is also specific for psoriatic arthritis is that it gives you a lot of tendinitis of the elbows, tendinitis of the Achilles tendon, plantar fasciitis, but also swelling of one finger at a time, swelling on one toe at a time, or inflammation in the eyes.
Wow. Yeah. Very interesting. Another question. Are there any genetic factors that may increase the risk of developing rheumatoid disease?
Yes, there are some genetic predisposition, some genes that will predispose you towards developing more autoimmune diseases, but none of our autoimmune diseases like rheumatoid arthritis or psoriatic arthritis are genetically transmitted from generation to generation. So that's the difference between the genetic predisposition and actually the genetic transmitted disease. For example, if you have someone in your family, like your mom, your sister, with rheumatoid arthritis, then there is a risk for you 3 times more to develop rheumatoid arthritis. And the same for other diseases. And I'm going to give you, for example, ankylosing spondylitis. If you have a gene that we call HLA-B27, you are predisposed, but not necessarily you're going to do the disease. Do we test for the gene? Do we test for these genes? No, because it doesn't gonna change the way that we diagnose people or we treat people with these diseases.
But it would be possible for a person to have the diagnosis of ankylosing spondylitis and does not have the gene?
Yes, there are patients that they have ankylosing spondylitis and they don't have HLA-B27 positive. There are multiple other criteria that we use to diagnose people with ankylosing spondylitis, and HLA-B27 is just one, but it doesn't mean that if you don't have that positive, you are not going to have the diagnosis.
Yeah, so at the end, it doesn't really help in the diagnosis because it might even confound you.
Correct.
Yeah. Okay. Another question. Is it common to be diagnosed with Sjogren's syndrome based on symptoms alone when the tests are negative?
Yes, this is actually a video in my channel about Sjogren that has 800K views. Sjogren is a very complex disease and unfortunately is not very well understood even by physicians. So when we think about Sjogren, first and the most important thing are the symptoms, the dry eyes, dry mouth, cavities, and many other symptoms that are neurological, but also other symptoms that can affect other organs. We do run blood work like the tests like ANA, rheumatoid factor, SSA, SSB antibodies, and most physicians will recognize Sjogren if you have those positive. But actually, we make a diagnosis based on the symptoms, on quantifying how dry are the eyes, how dry is the mouth. And then what is important, but also not helpful all the time, is the salivary gland biopsy. So if we get the salivary gland biopsy, and if there is a specific score that we found there, that plus your symptoms makes the diagnosis.
Oh, wow. What causes the Sjogren's syndrome? Do we know?
We don't know. Unfortunately, it's still under research and it's under the umbrella of autoimmune diseases. We think maybe viruses are precipitating this proliferation of our B cells that leads to Sjogren's syndrome, but we still don't know, or we still don't have a lot of options for patients with Sjogren, unfortunately.
Oh, okay. I will make sure that I will put the link to your video in the description here below, so people can watch the full version. Thank you. Okay, another question. Can cartilage, this is very interesting. I want to know your answer. Can cartilage destroyed by arthritis be regrown or replaced by anything more effective than the gel shots?
I think this is debatable, and it depends who are you going to ask. If you ask me as a rheumatologist, I'm going to tell you that it depends on the type of arthritis that you have, and then second, it depends on how severe the arthritis it is. Because as you probably know, cartilages, they don't have a blood supply, so they have limited ability to repair itself. But when the cartilage is at the beginning, let's say in the beginning after a small trauma, probably, and the data that we have, and it's coming now, is that regenerative medicine with plasma or platelet rich plasma therapy or stem cells, it appears to be beneficial in patients with early signs of osteoarthritis. But for moderate to severe osteoarthritis, I think the options are limited. We can try the shots, we can try the steroids, and eventually joint replacements are the solution.
And if you allow me to interject a little bit on your, because
Please do.
yeah, I do tell people that the cartilage may be destroyed, totally gone, but not necessarily their pain needs to be caused by that problem. I think people want to regrow the cartilage, not just because they want to have a new cartilage, but because they want to have less symptoms. And we know that if we x-ray, for example, people who are asymptomatic, they don't have any pain, they might be in their 70s, 80s, 90s, they're okay. They don't have any pain in their joints, their spine, their neck, the lower back, or the hands. But when you look, they have no cartilage at all. Because they lost that. That was the case of my grandmother. She was 92 and she needed an x-ray of her neck, not because she had any pain, just because she had a fall. And when we looked at her x-ray of her neck, it was terrible. I have never seen the worst osteoarthritis in my whole life. She had no space between the vertebrae of her neck. And I asked her, Grandma, do you have neck pain? She said, no, never. I said, did you ever have neck pain? No, never. So this means that it's not because you don't have a cartilage there that you must have pain, or that your pain is coming from that lack of our cartilage. So we do need to understand what is causing the pain, and sometimes might be from the structures around the muscles that are tense and trying to hold the joint, the tendons, and that can be treatable. You don't need necessarily to replace every joint that hurts. I needed to
I love
interject it.
I love your intervention because that's what I tell my patients when they ask for x-rays. And I explain them that x-rays is just a picture, it's just a picture of showing there is something there, but not necessarily what the picture shows is correlated with the pain that you have. I love your intervention.
Pain is very different, and sometimes, in most of the times, it does not correlate with X-ray or even with MRI findings. Okay, we're doing good. We're on question 10 now. Is ankylosing spondylitis fully curable? What kind of lifestyle and medicine should a person follow if they have ankylosing spondylitis?
So ankylosing spondylitis, like rheumatoid arthritis, psoriatic arthritis, are all autoimmune diseases. And ankylosing spondylitis focus on the spine, but there could be other joints, peripheral joints affected. And it's very well managed with medication. It cannot be cured, but it can be managed with medication. And unlike 20 years ago or 30 years ago, we have so many options because we started to understand our immune system, and we created certain targeted therapies for certain molecules that produce inflammation. And I'm not going to go into details because there is so much to tell you, but when I talk to my patients, I always tell them, and I know that you are a big proponent of exercise, I always tell them, if you pair your medication with lifestyle modification, your outcome will be 10 times better than someone that doesn't do any lifestyle modification. And that's why I created even that course where I introduced them to the pillars. I would call it the pillars of lifestyle, from nutrition to exercise, that I know you are an expert into. I actually refer a lot of my patients to your exercises on YouTube because I find them so easy to follow, and I found them so thoughtful done for patients that are suffering with chronic pain. And then I teach them about the connection between the mind, the body, which is also important because when you deal with chronic pain, your mind will remember that. And it's like a vicious cycle. So you have to address the mind to get better, to feel better. And then I talk to them about sleep. So I combine all these pillars into, I would say, a formula. Of course, I cannot introduce them at once to all of them, but I introduce them gradually to change things that I know eventually will help them bridge with the medication to feel better.
Yeah, absolutely. Yeah, we have the same approach of treating conditions, and we see the person as a whole, not just a body part that is there hurting. Yes, I really like that approach. Okay, question 11. What is the relationship between pulmonary hypertension and rheumatism?
So pulmonary hypertension is one of the most complicated situations in a patient with autoimmune diseases. And there are some autoimmune diseases like lupus, mixed connective tissue disease, and especially scleroderma or systemic sclerosis. There are some forms of systemic sclerosis, like the limited form, that will cause pulmonary hypertension. And many patients that do not know that this is a complication or a possible complication, even if they have shortness of breath or severe fatigue, they don't go to be evaluated for that. I always educate my patients about possible complications because I want them to be aware. And if they start having shortness of breath or severe fatigue, I ask them to come back to be evaluated. And I always ask my colleagues, the heart doctors, the cardiologists, to help me in evaluating that, because you need specific tests. You need an echocardiogram, you need a right heart catheterization to make that diagnosis. But if you do have it, then we do have options to treat it these days. So that's why it's important to diagnose, to be able to address it in time.
And the first symptoms would be shortness of breath and fatigue?
Most of the time is shortness of breath and fatigue. Fatigue is it's quite common that
But but
as described.
fatigue is
Yeah,
also very common in these rheumatological conditions and chronic pain, so it might be difficult for them to find out. Yeah.
that's very true. That's very true. That's why they have to stay in contact with us. And for these diseases that I told you about, I always do monitoring for those things. So for systemic sclerosis, I might do an echocardiogram. Depending on the type of disease, I might do an echocardiogram every 2 years. Even if they don't have anything, I still do it to make sure that there is time to diagnose and treat.
I see. Very good. Another question. What are some effective strategies for managing knee swelling associated with rheumatoid arthritis?
So rheumatoid arthritis needs to be treated systemically, because if you just treat the knee, it's not gonna solve the problem of the other joints. However, there are patients that will have flare-ups. I mean, an inflammation at some point just in the knee. And for that situation, I do like to do a very targeted approach, like a steroid injection, because if you do the steroid injection, it's not like you give steroids by mouth, which will complicate the situation. Many patients will have diabetes, hypertension, and giving a high dose of steroids will complicate their diabetes, and it's going to cause high blood pressure and other side effects. So if you do a more targeted therapy, then the chances are they will recover sooner and better.
Oh, wow. Yeah, very good. And alleviates the pain.
It does.
Yeah, it's amazing. Yeah, those steroid injections are amazing. Too bad we cannot do too many. How many do you recommend, like a maximum per year in the same joint?
In the same joint twice a year.
Twice a year. But in total, if they have more than one joint, how many per year in total in their body?
I didn't have patients that will require multiple everywhere. Most of them, they do have kind of the same joint that will be bothersome. But sometimes they might have the right knee and then the left knee, and then they have a shoulder. But basically, in my practice, it didn't happen to be so many because again, you just have to understand rheumatoid arthritis is not a disease that you just treat with an injection. I have seen, unfortunately, I can give you an example of one of my patients that I've seen. I think a month ago, she had carpal tunnel syndrome and she got injections, three in one hand and two in one hand by a hand surgeon. And, eventually she said to the surgeon, this is not right. There is something wrong. Why do I have so many injections or the need for so many injections? And then she looked it up and she found that she might have rheumatoid arthritis.
Oh,
And she eventually came to me and she got the
good.
diagnosis right.
Too bad that they missed.
It happens.
So now we are going to talk about the cracking sounds. People love to talk about that. People get concerned about this, the sounds that our joints make. So why cracking sounds come from they're talking the question was specifically from the knee joint of a healthy person.
All right. So if we are talking about healthy persons, a lot of them will have cracking of the knees. So those sounds that you have, the popping, the cracking, that are not associated with pain, you just hear them. So you don't have pain, you don't have swelling, but you just hear those sounds is because the cartilage probably in your joints is not very even. So when you squat or when you stand, those sounds can come from the gliding of the cartilage on each other. But once again, if you don't have other symptoms, you should not be concerned about that as being something pathological or something related to a disease.
Now, if a person has a disease and they feel cracking, should they be worried?
I think so. I think at least they should get evaluated, especially when they start having pain and dysfunction. They cannot walk. They start developing swelling. They should go to be evaluated. Many of them will have menisci tears or will have wear and tear arthritis, but could be other types of arthritis as well. I have actually seen a patient with rheumatoid arthritis, and when she came to see me, first, she came in a wheelchair, and it was very hard to put her on the examining table. And when I put her there and I tried to assess her knees, you cannot believe what sounds were there. I mean, it was incredible. I've never heard something like that. But in a couple of months with the treatment, she did very, very well.
Good. That's good. Okay. Next question is about lupus. What can we eat or drink to help with lupus?
So lupus is another type of autoimmune disease, a little bit more complex than the others because lupus, unlike rheumatoid arthritis or psoriatic arthritis, it doesn't affect only the joints, not that the others don't affect other organs, but lupus, when it starts, usually comes with other symptoms like rashes, hair loss, sores in the mouth, a lot of lymph nodes. And what is specific for lupus, it can affect organs, like the kidneys can be failing very soon, the heart can be affected, the lungs can be affected. So lupus can come as a storm, as an autoimmune storm. And that's why it's important to have the diagnosis first, treat it appropriately, and stay in contact all the time with a rheumatologist because we know how to deal with these things. And once the disease is controlled, I mean, you are not under the risk to lose your kidneys or, your heart to be affected, then you can talk about how to change things for nutrition. And I know you are a big, big proponent of the anti-inflammatory diet. I look at your videos and I love it because that's what I talk to my patients. What is an anti-inflammatory diet? And I talk to them about the principles of the Mediterranean diet. I discuss with them because it's very hard for people to adopt a vegan diet or a vegetarian diet. But when you talk to them about the principles of a Mediterranean diet, they understand and they embrace that easier. And what to avoid, I think that has been said so many times, but it's not enough times to be said. Avoid processed food, avoid too much sugar, avoid too much salt, especially salt. It's going to trigger your autoimmunity process.
Yes.
Avoid unhealthy fats. Sorry, and a lot of alcohol or a lot of red meat. And in some people, gluten can cause more inflammation, but not in everybody.
Yeah.
So just by eliminating gluten is not going to make a huge difference. But it's important to understand what we eliminate, but it's also important to put back the things that are causing less inflammation that you talk about, I talk about,
Mm-hmm.
you know, a lot of whole foods, whole grains, a lot of fibers, because fibers will modify the way that our gut bacteria work, and they will produce some metabolites, the short chain fatty acids, which will decrease eventually inflammation.
Yeah.
And if people are interested, I can talk a little bit about the supplements that were found to be beneficial
Yeah,
in
please.
lupus. So a lot of people are interested to know what is the scientific evidence behind certain supplements. And when we talk about lupus, there are certain supplements, and one of them is N-acetylcysteine. N-acetylcysteine was known to modulate certain types of T cells or T regulatory cells in our body, but there were many studies done in animals and models of animals with lupus. Last year, we had finally a study in humans with lupus that had all the symptoms of lupus. And then besides the treatment that they got a supplement. So once again, treatment should be there plus the supplement. And those that got the supplement, the NAC supplement, they did better in terms of disease activity, with less pain, less inflammation, less inflammatory markers. And that was a grounding study because we finally saw some evidence for this kind of supplement. The other thing is vitamin D. Vitamin D, I test my patients all the time about vitamin D when they come to me every 6 months, or, you know, if their values are normal every year. But I do encourage them to stay on vitamin D, like 2,000 units per day, because vitamin D is also a modulator for our immune cells. And vitamin D actually was shown to decrease the risk of autoimmunity. And it was a study in 2022. It was called the VITAL study, which proved that. And then it was a follow-up study that was just published a few months ago that showed that those people that did not continue the vitamin D, they lose that beneficial effect. So again, it proves us that continuing vitamin D and keeping the vitamin D to a certain level is helpful. The other supplement, and I'm going to stop here, there are others, but we'll stop here, is the fish oil. Fish oil, as you probably know, is a very powerful anti-inflammatory supplement because of the omega-3 fatty acids that are in the fish oil. And there are studies in patients with lupus and rheumatoid arthritis that show that fish oil, it will decrease not only the disease activity, but it will decrease the markers of inflammation and the need to take more medications. Because a lot of our patients, they use NSAIDs or non-steroidal anti-inflammatory medication, which can increase the risk for heart disease, kidney disease. So if you have a disease that it will increase the risk, like lupus. It will increase the risk for heart disease or kidney. If you take anti-inflammatory medication, that risk will be double or triple. So instead of using that, you may use a supplement, or you may eat a lot of fish to supplement the omega-3s in your body to help your lupus activity.
Yeah, this is so important. It always comes back to eating healthy, sleeping enough, exercising
Correct.
enough, and then a lot of your problems will go away. But we live in a very paced, crazy life that it's hard to follow all these things. Yeah. Good. Another question. Is an autoimmune blood work panel the definite way to check for an autoimmune disease?
Oh, I love this question. Thank you so much for asking me. An autoimmune panel is just there to guide us. It contains a lot of antibodies if you do the whole panel, which are checked to check for different types of autoimmune diseases. But what I want to emphasize, and once again, I put that in my channel as well, a positive NA test is not lupus. A positive rheumatoid factor is not rheumatoid arthritis. Because we as physicians, we have to pair the patient's signs, symptoms, with the physical exam and then with labs and imaging studies. So making the diagnosis of an autoimmune disease is so much more complex than that.
Yeah. It comes back to asking questions, examining the patient, seeing the other symptoms, and we combine that with the labs. Yeah, but a lot of people, I think they think medicine is much simpler than that.
Yes, it's the
And
easy
it's
route. We
yeah.
want to take the easy route, of
I
course.
wish it was that simple. Yeah. Okay, another question. As people age, the shape of the fingers change, including bending and thickening of the joints. What causes this, and what can one eat or exercise or generally behave to lessen this progression?
Oh man, this is very common. I have a lot of ladies, elderly ladies that will come into my practice and will ask these questions. So we don't really know why is this happening to begin with, but the reality is that if you use your hands a lot for repetitive motions, let's say typing, for example, then that might happen sooner. If you have that in your family, like your grandma or your mother, with changes in their hands, you might develop that as well. So there is a genetic component there, but we really don't know what exactly is causing the changes. There are some studies that they look back and they say maybe there is a little bit of inflammation happening in the joints and that will cause the shifting in time. But even that, we still don't know what is the truth back there. What to eat, we talked about what we eat healthy. That will apply to everybody. But to exercise, I think you are the expert here. I love the exercises of your hands, especially for people with osteoarthritis or rheumatoid arthritis, because as you say all the time, motion is lotion. So they should continue to exercise and water, drink a lot of water. Apparently, if you keep your body hydrated, that stiffness, especially in the joints as we age, it's gonna be less bothersome.
Yeah, absolutely. Yeah. Excellent. So, talking about exercise, the next question is about exercise. What kind of exercise is good for a person with osteoporosis and spinal stenosis?
I think you are the best person to ask or to me and to answer this question. I will tell you what I tell my patients with osteoporosis when they come to me and I see that they have severe osteoporosis, or in the first stage of osteoporosis, if I could say so, or the numbers are not terrible, then I do recommend them to exercise. And I recommend them weight exercises like lifting 2 to 3 pounds. They could do that. I mean, they could start with 2 to 3 pounds each hand, and then can work up. But I also recommend them to go do aquatics, like exercising in the water, because I feel like the water will take a lot of pressure off your body and you're not at risk for falling. For example, if you start running or if you start dancing, you can do certain moves, twisting. For example, twisting is bad for you. That can actually increase your risk of falling and risk for fracture. But if you walk, if you go to a pool, if you do these weight exercises, I think that could be safer. And you can add here if you want to.
Yeah, I love exercises in the water for my patients with pain, fibromyalgia, arthritis. But at some point, I tell them, especially if they have osteoporosis, that you do need to go to land. So start on the water and then go to the land, because you do build your bones. You put the calcium in your bones when your bones carry weight. So remember, weight bearing is really important. So they do need to do resistance, muscle strengthening exercises, and for spinal stenosis too, because sometimes they come together. which is the narrowing of the spine. It can happen in the cervical spine, but it's more common also in the lumbar spine. They need to do exercise that are positioning exercises that will especially open the spaces
Exactly.
of the lumbar spine. And there are some positions in the floor that they do to open the space to relax. And people with spinal stenosis, one of the main problems is claudication. They have claudication just means that you don't have pain if you're sitting or lying down, but as soon as you start walking, the pain starts. So you have to stop walking. That's called claudication. And that sometimes impairs the person's lifestyle and quality of life because they had plans to travel and to go shopping or to take their grandkids, to the zoos, and now they can't because they walk a little bit and they have to stop and rest and sit. But I tell them to start doing exercise in a stationary bike. So they increase the blood flow to their muscles and also walk a little bit stooped forward. They don't need to walk so pretty like a Miss Universe and Mr. Universe. They can stoop a little bit forward, and that opens the space in the lumbar spine and gives them a little bit more room for them to walk. Very good. We are at question 18. Can tendons and ligaments become weaker after menopause and can cause pain and weakness in the upper limbs?
I actually gave a recent talk about menopause and autoimmune diseases, and I have to tell you that that was very well welcome because a lot of people do not know that through menopause in the body, in the female body, there are a lot of changes. And one of them is the decrease in estrogen. So the decrease in estrogen, which helps our collagen to repair, it's actually the cause for our tendons to become weaker. So the collagen production decreases and the collagen quality decreases because of the lack of estrogen. And because of that, that will impact the tendons and they will lose that elasticity and they will become more stiffer. So that's why a lot of females will complain about being stiff in the morning when they approach menopause and during menopause and after. So yes, there is a connection there, and there are things that can be done.
So exercise would help with that and
Yes,
replacement of estrogen?
I think yes, hormonal replacement therapy comes back into our mind. I actually have talked recently with a specialist in hormonal replacement therapy, and although we thought 20 years ago that it's unsafe to do it, because there was a study about 20 years ago that showed that if you do hormonal replacement therapy, it might increase your risk for breast cancer and cardiovascular risk, like risk for heart attacks. But the follow-up studies that were done in the last 10 years, they show that is not so, this is not true. There might be people with an increased risk to develop those things, especially people that had family history of cardiovascular disease or family history of breast cancer. Of course, we're not going to give it there, but for other patients, the hormonal replacement therapy done properly by people that know how to do it, because there are a lot of people that they just open clinics to replace hormones, especially here in the United States. So under the right management, you can benefit of that, and that could be helpful.
Okay, good to know. Good to know. Okay, we have 2 more questions here. Is rheumatoid arthritis hereditary?
So we answered partially this question, and we said that there has to be a genetic predisposition to develop rheumatoid arthritis. It's not transmitted from generation to generation, but if your mom had it, then your risk to develop it is 3 times more than the general population. But on this territory, I would say, if you have certain risk factors, and again, if you are a female compared to a man, the risk is higher. If you encounter in your life certain viruses like certain viruses like CMV or EPV, the risk is higher. Then smoking. I tell all my patients to quit smoking because smoking, it's a very clear link between, even secondary type of smoking, like exposure to smoking, that will increase the risk for you, for your kids, and for the people that are around you. Obesity too. People that are more overweight, they will have an increased risk for developing rheumatoid arthritis. And even those changes that we mentioned in patients that transition to menopause, females that transition to menopause, the drop in estrogen will increase the risk for rheumatoid arthritis. Poor dental hygiene. So poor dental hygiene is very important because there are certain bacteria that apparently will precipitate inflammation and will increase your risk to develop rheumatoid arthritis. Nutrition, very important. So if you eat a lot of sugar, a lot of salt, that will increase the risk, and there are others too. And vitamin D deficiency. There are studies that prove that if you are vitamin D deficient, then your risk for developing this disease is higher.
Those are so important because some of the things that you said are modifiable, are things that we can control. We have control over them. Some are not, like our genes, we don't have control, or some diseases that we are affected. But all the other things that you mentioned, they're modifiable, lifestyle, we have a choice. And we only have one health. We
I
don't
agree.
have, plan B for our health. We need to take care of the only health that we have because if we lose that, there's no replacement. And getting sick is not fun and not cheap. We spend a lot of
That's
money.
very true. That's very true. I always tell to my patient the same thing. You cannot modify your genes, but you can definitely modify these kind of factors in your life, and they will have the greatest impact on how you live your life.
This is also epigenetics. I came
Correct.
across, epigenetics recently. You're born with the genes, and so
Correct.
epigenetics is the connection between nature and nurture. You're born with the genes, but then the environment where you live are going to determine which genes will be exposed
Express.
and expressed, and which ones will be inhibited. And air pollution, nutrition, and chemicals and things that we put in our body, like smoking, nicotine, and alcohol, will affect how these genes are expressed.
Very true.
Okay, we are here to the last question. Very good. What are some effective non-pharmacological approaches for managing chronic pain in patients with a rheumatic condition?
This is what I do every day. I bridge, the traditional Western kind of medicine with the non-pharmacological approach. I educate people every single day about how to bridge those two worlds because one without the other might not be enough. And that's what I started in my company, Rheumatologist on Call, to make this kind of approach personalized, comprehensive, and to help people bridge these two worlds. And I know that a lot of people, they want just the natural way or just the pills, but I always find that one without the others might be very difficult to manage these autoimmune diseases at this point. So when I created my practice, besides the time that I invested in my medical training, I took time and I invested to learn about nutrition, mindfulness. I went myself to educate myself as a physician about those things because, as you know, in our medical training, we probably have 4 hours of training about nutrition. So that's why many physicians, they feel uncomfortable to talk about nutrition, or they feel uncomfortable to talk about the gut health or to talk about mindfulness. They don't even understand how to put that in their practice. And besides that, there is no time. You know that, especially here in the United States, the regular practices, they have 15 minutes for a new patient and 7 minutes, if 7 minutes, for a follow-up. So what can you achieve in that time? See the patient, write your orders, talk to the patient, write your notes, put the orders, code, bill, and then educate the patient. And there is no incentive, for the physicians here in the United States. I don't know how it is in Canada, but here there is no incentive to talk about lifestyle with the patients. There is no code for that. There's no way to bill. So you don't have the time, you don't have the knowledge, or if you have the knowledge, you have to prioritize what are you doing in your practice. So that's what I do. I took time and I built up something different because I felt like the patients will not get better without this extra knowledge. And I educated myself in nutrition. I went to Stanford, took a nutrition course. I went to University of Massachusetts. I did a mindfulness course because I wanted to understand myself, how can these tools are valuable for my patients? And the reality is that they are huge. They make a huge impact. Not only that it's going to connect the patient with you to multiple levels, because now you're not only the doctor who hands you a pill and moves you away because he has 3 other patients, but he educates you. He is there with you to partner with you, to teach you how to do things, to reinforce things, because that's also difficult. The patients, if you dump a lot of information on them, they don't know what to do with that information. That information can be found on internet, but there is no strategic approach in how you do that. So that's why all these pillars that we talked about and you talk about all the time, and I want to congratulate you for doing that, because there are not many of us that we are strong advocates of lifestyle, especially on social media, people that we are educated and we have the expertise, but we are also willing to give our time and expertise for our patients and for people around the world.
Yeah. You just said so well at the end. I'm glad that you said that because we have the same philosophy. That's why I opened my YouTube channel too, because I don't have a lot of time with my patients and I wanted to spend more time with them educating. So I decided to do the channel for my own patients, but I guess more people also liked our messages. So congratulations on your channel too. You are doing really well. And I hope you're getting gratification. You know, I know people write comments to us, so I invite people to write comments today on this video. Was this helpful to you? What kind, or if you have more questions, maybe we can do a session 2 with Dr. Genita. If you write more questions here, say, you know, I have ask more questions of the rheumatologist, we'll do that. And thank for everybody who submitted questions today. As I said in the beginning, I'm going to post all the links, how you can find Dr. Genita's website, course, YouTube channel, Instagram, all in the description of this video below. And I'm happy that she agreed to do this today. And thank you so much for you for watching today. Don't forget to subscribe to our channels, mine and Diana's channel. And also, if you need a second opinion about a rheumatologist wherever you are in the world, don't forget to connect with Rheumatologist on Call and book your appointment with her, because she does that. I don't do that yet, maybe one day in the future, but she does, so you can have a second opinion with Dr. Genita. Thank you so much for watching today. Have a wonderful day. Thank you, Genita, for being here.
And thank you very much for having me. I feel honored and I congratulate you for all the work and efforts that you put in.